Good morning, everyone. It's very bright and early here. In fact, well, actually, that's a lie. It's not bright at all, but it's very early. Uh, Welcome to another Thursday VMR. We're very, very excited for yet another round, as we are every single time. And today, as is becoming a theme, it's an all academy affair with Julia, who has some epic scenery to tell you about, scribing. Elena is doing teaching points, and our very own Mukund is presenting. Why don't we pass the mic to each of you guys to say hi before we talk about the case presenter? So, Julia, I'll hand the mic to you.
Hello, everyone. It's so nice to see you again. My name is Julia. I'm a medical student from Germany. I'm very excited for the case today.
Hi everyone, I'm Elena. I'm also a medical student and I actually went to university with Julia together. I'm super excited for Leah's discussion and the case of Mukund, who apparently is an early bird now. So yeah, excited for that.
Trying my best. Hey everybody, I'm Mukund, fourth year med student from UCS staff.
Oh my gosh, you guys are amazing. It's so cool just to see how well you're getting to know each other, even though many oceans and whatnot separate some of you, although not all of you. You heard that Julia and Elena are from Germany, and our case discussant is very close by. Uh, and I think Leah and I were just chatting about trying to figure out how many times we've had the privilege of doing this, and we couldn't quite figure out exactly. But Leah's been one of the longest serving members of this VMR community. It's been years and years and years. And I'm super excited to do this. I think I worry a little bit, Leah, that this might be the last time for a while as you go off to busier and busier times. So I'll pass the mic to you to say hello and tell people why it might be a minute before we get to do this again and celebrate it even more today.
Yeah, hi everyone. I'm Leah. I'm from Austria, so close by to Elena and Julia. And yeah, you asked why this might be the last time before a lot busier time for me, and it's because I'm soon gonna start my intern year and then going on to work, and I'm really excited about it. Also a bit nervous because it's new, but I think that's quite normal. We're having new things come up, but I'm really excited because I'll go and pursue a passion of mine. I mean, internal medicine in general is a passion, but I get to focus also on rheumatology in my training now these next years. So I'm really excited about that, and got lots to learn, but that's a good thing.
I feel you. I feel like rheumatology is just the coolest. And who knows, maybe Mukund will spring up a surprise for you to get you some early rheumatology practice or not. We'll see. Mukund, we're ready to rock and roll whenever you are.
Okay, that sounds good to me. I'll start with the first aliquot. The chief complaint is right lower extremity pain. And for a brief first portion of the HPI, this is an 84-year-old male who presented to an outside hospital with fevers, chills, weakness, and right lower extremity pain for 2 days. He was recently hospitalized for diverticulitis complicated by an abscess and was treated with 2 weeks of ceftriaxone and metronidazole. He was discharged 1 week ago. This morning, he fell and presented to the emergency department and reports right lower leg pain. He denies any head trauma. That's the end of the first aliquot.
But yeah, I'm curious, what thoughts are crossing your mind? Where are you at?
Okay, that is very interesting because I think, Mukund, as you told the story, the problem I tried to solve in my head changed and changed, because at first I had right lower extremity pain, and in my head I was thinking about the common things of unilateral leg pain. We think of DVTs, we think of cellulitis, maybe there's some trauma, something. And then also in my head I was going the anatomic approach, what is there, what could hurt in the extremity. But then it continued, and we had a background for this patient. We had this recent hospitalization with fevers and chills, so an inflammatory process already going on. So I was thinking, okay, could this then also be something inflammatory with the right lower extremity pain, or maybe it's unrelated. So we can't really say much yet about what happened there. Maybe, and then we heard about the fall, so the trauma, and that changed it again for me, because now I want to see the patient, I want to see the foot. Is there something that hurt, or like visibly or invisibly, but it's like a traumatic injury that might just explain this right lower extremity pain of the patient. So I think looking at this patient would give us a lot of clues, and it's still unclear to me what the problem is to solve here. But in an 84-year-old male, just to comment on that, we don't really know what the relationship with the hospitalization, the diverticulitis, and the treatment is. But one thing we can think of is also treatment-related complications. And we know, I think maybe that it's because we also had a case of this, but for example, antibiotic-related encephalopathies and old people who just fall because of that, might that have caused just the trauma? And actually, but that's not then again the problem, because the chief complaint is right lower extremity pain. So now we have to find out what we're actually solving here.
Now, the only thing that I will say of meaningful substance is I really hope that you take the opportunity after the session to maybe watch the first time you discussed and to rewatch this. I think that'll be the most illuminating thing, because for me, it's certainly very prominent how effortless it is for you to articulate your thinking. And for those of you who are just watching, I think you're probably like, oh, like this seems so easy just to be able to discuss like this. And I think you're making it seem very, very easy. And I'm right there with you. I think that the core tension in this case is whenever somebody presents with a single extremity that's hurting, it's often a local disease. And so looking very closely at what that is with your eyes and your hands often tells you exactly what's going on, because it's so local and it's often at the surface. But I think the tension in this case is this person has a local manifestation in the with the right lower extremity, but has prominent systemic features. And so is it such that this person has a severe local disease that's causing disseminated consequences, like really bad cellulitis, for example? Or is this a systemic disease that is showing up asymmetrically in the leg? And the clue that it's showing up asymmetrically in the leg is it's already showed up somewhere else in the belly. And so I think you're right. We have to be very, very careful and try to make sure that we identify the correct problem affecting this patient. Since this has been the theme of VMR in the last 2 weeks, my advice to you is if any individual diagnoses are crossing your mind right now, it's probably the result of conditioning by taking exams and tests. There is no reason in real life that any individual diagnosis should be crossing your mind. The only individual diagnosis that's crossing my mind is acute limb ischemia. The reason for that is not because it's probable, but because it is very, very easily missed. What this person could be having is all sorts of devastating infections or whatnot. But the only diagnosis that crosses my mind actively when patients has a focal extremity pain is one that is much harder to diagnose in real life than the textbooks. That's because patients with acute limb ischemia can actually have palpable pulses. They can have all sorts of things that will fool you. And so I am right there with you. I'm trying to figure out what the problem is, intrigued by the local flavor of focal extremity with the systemic features that this patient is having. And I'm really, really open to anything like you are, and we'll see where the dust settles, but I think it'll be crucial not to let go of ischemia until we have found some other vacuum to explain that. All right, Mukund, tell us more.
Yeah, I'm really liking this case. This is one of the most interesting, I think, for me, VMR cases that I've put together. I think just because at every aliquot, the differential has just remained really broad. And I loved hearing both of you talk about it. Just also, as a postmortem reflection on my own thought process. He's doing patient staying time, but on my thought process, I should say. We'll move on to the second aliquot. this is where it gets pretty interesting. Past medical history includes hypertension, insulin-dependent type 2 diabetes, chronic kidney disease, severe peripheral artery disease without revascularization due to surgical complexity, unprovoked DVT on lifelong apixaban, heart failure with preserved ejection fraction, a right knee replacement secondary to severe osteoarthritis, chronic inflammatory polyarthritis, and a mutation and biopsy positive VEXAS syndrome, previously trialed on tocilizumab, azathioprine, and now on ruxolitinib and chronic prednisone. For medicine, he takes ruxolitinib, prednisone, Bactrim and acyclovir prophylaxis, and insulin. The family history is non-contributory. The social history, he lives independently but supported by his son. As far as health-related behavior, he smokes cigarettes, has 30-pack year smoking history, and drinks 2 glasses of wine daily. That's the end of the second aliquot.
Oh, well, you know, most of VMRs are about diagnosing VEXAS, and here Mukund is presenting an elite level case where VEXAS is just background information, no big deal. Wow. Yeah, I'm curious. You're going into this field in the future, but before we talk about everything else, I wonder if we should, just for folks who may not be familiar with this very new condition, I'm curious what your knowledge space is of that condition, and if it's new to you, I'm happy to elaborate so that that's not confusing for many people.
Yeah, I'd love to, and then you can expand on what you think is also relevant. But VEXAS syndrome, it's been recently discovered, and it's actually, I think, Room and Team are 2 specialties who kind of share this disease, and it's an autoinflammatory disorder. So often, and it's a mutation, but it's acquired. So often it can be in adulthood, and it's X-linked, that's what the X stand for. So it's usually in male patients, as also in this case. And they might have recurrent fevers and inflammatory flavor. And then the VEXAS is actually an acronym for vacuoles and X-linked. And I always forget the others. So you should look that up yourself. But I think it's the mutation in the ubiquitin gene. And because of that, they have these recurrent autoinflammatory episodes. And there are many diverse presentations of it. But in one talk, I once heard that one characteristic that is often present is the macrocytic anemia. So I'll be very curious to see also what then the CBC of this patient is like. And thank you. I'm just seeing that in the chat, they expanded on the acronyms, what that actually means. And it's good to know that the A means autoinflammatory, because that then helps me to remember it next time. But yes, so basically it's the syndrome that is autoinflammatory, lots of heme manifestations as well, can have cytopenias too. And so that's about VEXAS. Rabih, do you want to add something?
I think, no, that's absolutely superb. I think the thing that defines VEXAS is a somatic mutation in the UBA1 gene that is X-linked. The fact that it's X-linked and a somatic mutation means the vast majority of patients are men. And because it's somatic and acquired, it's often older men, though as we learn this disease, you'll see that increasingly female patients are being reported. So that's the disease definition, is you have this somatic mutation. Now, why the heck would you go looking for it? And the core hematological features are the most consistent. So a macrocytic anemia is present in about 95% of patients. A year ago, the number was 100%, but more and more so we're learning it affects more women than we realized, and that not all patients, but vast majority, 95%, have a macrocytic anemia. There are other hematological fingerprints beyond macrocytic anemia, including a much higher rate of aparaproteinemia. So the general rate of MGUS, or of a paraprotein, is about 1% in the population at age 50 and goes up thereafter. In patients with VEXAS, they have a 25% of having a paraprotein. Patients with VEXAS also have a unique combination of other hematological fingerprints. Some of them have eosinophilia, and some of them have a myeloproliferative phenotype. So the heme is actually complex, but remember the disease definition is having this somatic mutation in UBA1 gene. There are visual correlates of that with the vacuoles on bone marrow biopsy. And there are also plasma cell correlates like the paraprotein, and also myeloid correlates like the eosinophilia. So it's a very messy hematological disease. And that messiness also bleeds over into the rheumatological world. And the rheumatological world can be divided into surface manifestations and visceral manifestations. So things that show up on the top of the body and things that can show up deep inside. This approach of surface versus visceral is very analogous to another mysterious disease, Behçet's disease, where patients have a lot of surface manifestations and their key visceral manifestation is a vasculitis. And the same is true for VEXAS. The key underlying visceral manifestation is a variable vessel vasculitis, which affects all vessels of all kinds, veins, arteries, and capillaries. And it manifests in the form of thromboembolic disease, just like Behçet's, but also in a vasculitic syndrome, most akin to a seronegative vasculitic syndrome like polyarteritis nodosa. There are other internal manifestations, most notably interstitial lung disease, but vasculitis thromboembolism is the one to really hold on to. The surface manifestations are very similar to Behçet's in that they are centered around the face and the skin and the extremities. The facial manifestations akin to oral ulcerations in Behçet's. I'm trying to draw an analogy here to simplify the linkage of this disease to something we already know a little bit better. And in fact, the diagnosis to last week's Thursday VMR is unlike oral ulcerations, the key manifestations are, the core manifestation is recurrent chondritis of the ears in a manner akin to relapsing polychondritis. But patients also have significant ocular and orbital manifestations. And unlike Behçet's in that it affects the skin, where Behçet's characteristically causes folliculitis and an acneiform rash, the characteristic manifestation of VEXAS on the skin is a neutrophilic dermatosis like Sweet syndrome. There are other manifestations on the skin, including urticarial manifestations, which are more common in patients who have the eosinophilic fingerprint that we reviewed earlier. So if you're trying to understand VEXAS, you'll understand that it is a somatic mutation in UBA1 gene, disproportionately affecting older men with a predominant macrocytic anemia, featuring other hematological abnormalities. The spillover to rheumatological world is often manifest at the surface, usually on the face and the skin, the ears, the eyes, and nodules on the skin. But the deadliest thing about it is that the visceral manifestations of vasculitis, akin to Behçet's disease. As is true for this patient, a large fraction of patients have other visceral manifestations like lung disease and inflammatory arthritis, which I forgot to mention because it's just so nonspecific. But it's very, very prevalent in these patients. So that's the context in which we have to analyze this patient. And he's, of course, immunosuppressed as a result of that, which opens up the whole other panoply of symptoms. I'm curious, Leah, how are you merging now more common conditions that he has, this rare condition, along with the fact that he's immunosuppressed, with what he came in with? How are you trying to synthesize it?
Yeah, to be honest, I can't, because there's so much going on. I still have a hard time to say what the exact reason is. I think what it does for me is just opens up so many possibilities. And I would love to know the labs of this patient to just see also the state of one, immunosuppression, but also coagulopathy or not, like what that is for this patient. And because he's also on apixaban, and that's hard to see on labs, but what I wanted to what I was also thinking, was he falling and then was there a bleed? Because compartment syndrome is also something that is important to think about. But then we have this hypercoagulable predisposition with this patient, and also lots of risk factors. I mean, he had unprovoked DVT in the past. He has lots of risk factors for ischemic limb disease. And what is also going to be interesting is I saw this patient was on tocilizumab, which is an interleukin-6 antibody. And with interleukin-6 antibodies, we have to be careful then later interpreting the inflammatory labs, because the CRP, which is one of the main markers that we use, is actually greatly impacted by interleukin-6. So we can't reliably look at that then as our marker later on. And just one thing that might be interesting here in this case, because a common complication of tocilizumab is also diverticulitis. And that is, I think, I can't explain why exactly. It's just tends to be a common complication that one has to be aware of that. Maybe it's because of a particular type of immunosuppression, or I don't know, but this is, I can't give the answer. So I'm still kind of trying to figure out, I can't narrow down my differential or problem at the moment. For me, it's more expanding.
Oh my gosh, I feel like you're already a rheumatologist. Those were two things that you just mentioned at the end that I had no idea about. I just made a note to read about tocilizumab and diverticulitis and the effects on CRP. Yeah, I think your reasoning is spot on, and I think the only thing I can add is just to shed light on a similar circumstance that I experienced yesterday. I had a patient who came in by ambulance, and so I worried, and I as the nurses were helping the patient set up in the bed, I went and opened his chart, and I saw that he had a panoply of conditions. He was post-renal transplant. He had adrenal insufficiency. He had PJP, CMV, aspergillus. He was sick as can get. And I was looking at his chart and trying to understand him and spent 5-10 minutes looking. And I walked over and finally tried to figure out what he was here for. And what he was here for was that he had a mechanical fall and sprained his ankle. None of the conditions were relevant. Now, what is the point there? The point is, it doesn't matter what background the patient has until you know what the foreground is. And if this patient came in and says, hey, I have a little pimple right here, you'd be like, I don't think that any of the medical history is relevant. And so this is just a silly way of making the point that the foreground is really all that you need to understand before you try to synthesize it. And I think the tension that you're feeling, Leah, is we don't really know what the core problem is right now to be able to use the medical history to our advantage. And only when the core problem crystallizes will we be able to go back and be like, okay, how can we actually use this to our advantage? So I think the exam will be very, very telling here. All right, Mukund, Mike, to you.
Yeah, love the discussion. I think I was in the same boat at one point, kind of trying to decide whether this was an everyday concern presenting in an extremely complex patient, or if the Vexus really had something to do with any of this. I think I'm still in the stage of my education where I kind of gravitate towards rare and interesting diagnoses, but it was very possible that this has nothing to do with his very intense and involved medical history. But we'll move on to the next aliquot. As far as vitals, I had a temperature on admission of 38.1 Celsius, which is a little high, a heart rate of 106, a blood pressure of 154/67, respiratory rate of 22. His cardiovascular, pulmonary, ear, nose, and throat, and abdominal exams were all normal. On his extremities, there was redness and swelling that was noticed from the right upper calf all the way to the ankle that was tender to palpation, but without any open wounds. There was a small dressing in place. And just to clarify, I'm at UCSF. This person was admitted to an outside hospital and was transferred to us. So to kind of be authentic to the way I was seeing this person, I'll give you a little bit of background context here as well and say that at the outside hospital, the records we received were limited. But we know that he was started there on empiric ceftriaxone for cellulitis. And that given his history, they actually just went ahead and consulted derm right away. they biopsied. They don't have the full report, but from what we can tell from notes that we can see, there was, quote, no evidence of vasculitis on the biopsy. However, and this is the reason for the transfer, the labs at the outside hospital showed pancytopenia, and he was transferred to UCSF for complexity.
Gosh, Mukund, this is so interesting. Maybe I can just clarify the exam real quick. So it sounds like he has um redness and swelling from his ankle to the upper calf. I may have missed it. I'm curious, does it involve his foot as well? Is his foot swollen and red, or yeah, can you shed light on sort of the other element?
Yeah, it's really just that finding. His foot is not involved, and neither is his knee, the joint itself, or anything above it. Just the swelling of his calf.
Swelling of the calf itself. Okay, gotcha. And then you said he has open wounds. Are the open wounds in that same area as well, or?
He doesn't have any open wounds besides
see.
the small one that the dermatologist created for the biopsy.
I see. Okay, gotcha. Without open wounds. Okay, thank you very much. Super helpful. All right, Leah, what are you thinking here?
Yeah, so I feel like this is a very complex case because I'm trying to understand. So he was treated for cellulitis, presumed cellulitis in this outside hospital, but there was no improvement. Did I get that right, of the symptoms? Which is already an important clue for me, to see, okay, what they gave him, did that improve it or not? I would still, when I heard first time the swelling of the calf, I was thinking of DVT, and my head wanted to do an ultrasound of the veins to kind of exclude, is there something that obstructs this or not? But then the distribution, it seems kind of weird, very segmental. This is a question for me, for you. Why exactly did you ask about the foot involvement? Does that help you differentiate between DVT and other causes? Or what, yeah, maybe that is a question that I have. And then I think the finding that is very, like a new problem that is coming up now is the pancytopenia. And I think I have a hard time, is it okay already to kind of try to map on, like make connections of the past medical history of this pancytopenia, or should we start anew? And I think it's maybe easier to like start what is our basic approach to pancytopenia and then think, okay, can we link this somehow to the past history of the patient? So when I think of pancytopenia, I want to know, is it a destruction or production problem? And I think there are way more options in my head that I can think of how it's a production problem than a destruction problem, because all of these, to have all of these cell lines be destroyed in the periphery, maybe I should have added that periphery, it's less likely for me. But then here, maybe I can ask, is there some information about acuity? How fast did that develop or not? And then what's interesting for me, or maybe thoughts that opened up and questions, is pancytopenia. That means this patient is at risk, even more at risk of infection, besides all of these other risk factors that the patient has because of comorbidity immunosuppression, medication immunosuppression. So risk of infection is very high, and I still want to make sure that there's nothing I miss. Even recently had infections. And then the other thing is, with low platelets, I would also expect bleeding risk. And then in my head, this is a question of, okay, but with these other risk factors, is the DVT still more probable because of the comorbidities? So I'm kind of, as you can see, I'm kind of thinking out loud, but not quite sure. I think this is just hypothesis. I think in practice, you would have to be, okay, what is my structured approach? What is the workup we would do? Can the medications cause pancytopenia? Has there been a recent infection that might suppress the bone marrow? Is there bone marrow infiltration, which might be linked to VEXA syndrome or some kind of disease with that, maybe get a smear, look at the cells, see should we actually look at the bone marrow. Are there hints that the bone marrow is not working properly, like low reticulocyte count? Because usually the body would want to compensate for the lack of cells in the periphery. But yeah, I think still very confused with all the complexity here.
Yeah, no, I think there's a lot of complexity. I don't think there's any confusion, honestly. I think there's a lot of inherent uncertainty in this case, but the problem is starting to coalesce, right? Like you now know that the extremity problem that the patient came in with is one that is restricted to the calf. And I think that helps you because the probability of acute arterial ischemia or acute on chronic arterial ischemia is much lower when the foot is not involved. And especially when there's no foot breakdown. So you're like, okay, I am going to invoke the common things I see with foot swelling that isn't limb ischemia, which is this cellulitis or is this DVT? And I think given the patient's hypercoagulability, a DVT ultrasound will be illuminating. And as you just said, cellulitis remains a consideration, but also expanding the possibilities for what the organism might be, given the fact that this person is both immunosuppressed from the outside, but also now from the inside. And so I think that the problem that we're solving is a patient who has a chronic hematological rheumatological condition, who now has acute pain and swelling in the right lower extremity, pancytopenia, and systemic features. And I think the first question to ask is there any reason for empiric treatment right now without any diagnostic clarity? And the answer is that yes, he probably now has neutropenic fever based on the fact that he's pancytopenic and fever and febrile. So that's one of the four conditions for empiric treatment without knowing what the answer is. And the other is sepsis, decompensated cirrhosis, and Riegering. Those are the four, just to say them very quickly. So you probably need to treat this person empirically. And as you treat them empirically for neutropenic fever, you now have to try to make progress on the pancytopenia and try to make progress on the leg. For all patients who have a leg syndrome that is inflamed, that have systemic features, you really need to find out how deep it is. So the next step that I would be trying to do is to get a CT scan to understand, is this patient having bony involvement, muscle involvement, fascial involvement? Because I think that step will be very, very illuminating. And so you're trying to figure out what compartment of the calf is involved and what compartment of cytopenias is involved. Is it the marrow? Is it the spleen? Is it a nutritional issue? Is it an effect of a medication? And I think once you are able to localize the lesion in each of those compartments, you can try to synthesize this better. But the only thing you have to do beforehand is to be very mindful about empirically treating the patient because he has neutropenic fever. And because he's immunosuppressed now from the outside and inside, you have to remain vigilant that these two threads that you've picked up on, cytopenias and leg, are not the only ones, and that he may have subclinical involvement of other organs that you may not appreciate based on his immunosuppression. I would say the most important organ to consciously track right now are the lungs, as the lungs are a common portal of entry for devastating infections that can seed the skin, especially angioinvasive fungal infections that may have minimal to no lung issues initially. So you might be looking at that screening X-ray for admission even more closely. And if things evolve to even a cough or a tinge of hypoxemia or mild tachypnea, you probably would follow up with a CT scan. So I think the background here is the immunosuppression and its treatment has become relevant. The presumed foreground is cytopenias and leg issue. The depth of those problems and where they live is yet unclear. Being vigilant to other clues emerging in other organs, and also not sitting on this and just pursuing a diagnostic workup because the patient has probably has neutropenic fever. If you have us on the edge of our seats, because this is very, very complex, a lot to juggle here. How did you guys make progress?
Yeah, I will give you, so I have two more aliquots. Since I was on the hematology service at the time, you were going to get a heme aliquot now. So for labs, white blood cells of 2.6, of which 1.6 were neutrophils. hemoglobin of 9.4, platelets of 45. For chemistry, a BMP was normal except for a creatinine of 1.53, which was around his baseline, CRP of 15, ESR of 25. Then for some more heme labs, reticulocyte count of 1.8%, MCV of 109, iron of 18, transferrin of 152, which is low, transferrin saturation of 12%, which is low, ferritin of 861, which is high. Total bilirubin was 0.8, an LDH of 265, with the upper limit of normal at our lab being 243. Coags were normal. Fibrinogen was 332, which is normal. And folate and B12 were both normal. For a blood smear, we saw bands, many bilobed and hyposegmented neutrophils, occasional elliptocytes, dacryocytes, and normal platelet morphology. Viral serologies, including hepatitis panel, HIV, COVID, and respiratory viral panels, all normal. And as far as infectious workup, a MRSA NARI swab was negative, and blood cultures ×2 grew nothing over the course of 4 days.
Good, you're presenting this like a pro. Thank you so much for the heme aliquot and the very logical data that followed. I just want to maybe you can help us with the numbers, because I think you mentioned the reticulocyte percentage. You know what was the index appropriately high, or was it unimpressively low? Do you remember?
It was inappropriately normal.
Perfect. Thank you. All right, I saved you some math there, my friend. What are you thinking?
Very grateful, and the term heme aliquot too. So yeah, we have got a lot of new information. We have the pancytopenia confirmed. However, I was curious to hear that it was interesting to hear that the white blood cells were low, but those that are present are mostly neutrophils, if I understood that right. So actually, we have a disproportionate amount of neutrophils, and it's more lymphopenia that we have in this case, which is interesting to note. And then we have low iron studies, high ferritin, and also reticulocytes are inappropriately normal, indicating that production of red blood cells is inadequate in the bone marrow. And the smear is interesting because we have hyposegmented neutrophils in the blood smear. And what does that mean? When we have, it's the neutrophils that are still younger in their development. And you can have a lot of hypersegmented, or we call them bands, also in acute infection, when the body tries to quickly give neutrophils. So they say we don't have time to give full maturation. We're just gonna give you the younger ones too. But then also when there's a defect in, or not the appropriate maturation, that also makes me wonder about hematologic malignancies too. So I have these two thoughts in my head. And then the dacryocytes, dacryo actually comes from the word tear, and I always have a Rez's voice in my head who says it's the bone marrow that's crying when they cry out these tear cells. And what can cause dacryocytes? It can either be an artifact when you do the smear, and the clue here could be they're all looking in the same direction. So that's just one thing. But what I suspect here is that it's a problem with the bone marrow, that it's infiltrated with something. And when these cells exit the bone marrow, they're kind of squeezed through and they have this weird or odd shape. That's how I explain myself dacryocytes. So I am wondering about what is going on in the bone marrow, and why are there disproportionate neutrophils present? Is there something infiltrating or not? Is there some fibrotic process in the bone marrow? And yeah, and is there also a neoplastic process? These are the two things. Or hyperproliferative, even if it's not monoclonal. So I would want to know, is there a clonality in these cells? Or are they just proliferating a lot, hence the term myeloproliferative disease? And why did they do this infectious panel? This could also be interesting for us to know, because hepatitis, COVID, the respiratory virus, HIV, they can all cause aplastic anemia, which can cause pancytopenia too. So that's, for me, an important workup too that they did. And so I think at this point, just looking at my focus now is more on the pancytopenia, because now we have a thread to follow. And what I want to know, what can cause this disproportionate, weird young neutrophils in the periphery? What does the bone marrow look like? I would want to know, get an aspirate of the bone marrow to see what it looks like there. And then maybe we do have a hematologic proliferative or neoplastic process that can also explain the hypercoagulability and maybe a DVT. So we still have to solve the problem, what's going on in the foot or the leg.
Absolutely superb. I think you've narrated it very, very well. Here, I think I would, in pancytopenia, the fact that the reticulocytes are not high tells you the bone marrow is on the hook. And the simple question to ask is the bone marrow on the hook because it's hungry and it has nutritional deficiencies? And that's not been the case with Mukund's workup. So the bone marrow must be on the hook because of something in it. And so you can predict that the bone marrow biopsy will be positive in a patient who doesn't have a nutritional cause of pancytopenia. And so the question is, what might the bone marrow biopsy show beforehand? And it might be either empty or full. And if it's empty, the cause of that would be aplastic anemia. And I think that is probably the workup that Mukund and his team were doing peripherally, because all the viruses are associated with aplastic anemia. But the prediction that the bone marrow is empty is low because of what you just said. There's something crowding it out and making the bone marrow cry. And so the question is, what is something that's crowding it out? And there are really fundamentally three different possibilities. There's a fibrotic reaction in the bone marrow, i.e. bone marrow fibrosis, often due to myeloproliferative neoplasms, but can be secondary to something else. Granulomatous infections or disease processes that fill up the bone marrow with granulomas, or cancer. Cancers can be acute leukemias or metastatic cancers, lymphomas and whatnot. So any cancer can invade the bone marrow, primary like leukemia or secondary. So the question is, does this patient likely has a bone marrow process, a space-occupying bone marrow process. Is it granuloma? Unlikely based on the exposure history. Is it fibrosis? Possibly, because of the progression of MDS to the myeloproliferative neoplasm type that we talked about earlier. Or is this a cancer? And the most concerning cancer here would be that the patient has acute leukemia. The word acute leukemia might be a paradox here, because Mukund and his astute team have not found any leukemic cells in the blood. How can you have leukemia without leukemia? And about 15% of patients have what's called aleukemic leukemia, where there are no blasts detected on the peripheral smear, either because the sensitivity of that random test is not perfect, or that they actually never have leukemic cells going into the blood. And so I think that because we're making so much progress on the bone marrow, I'll just share that the connection between the skin now invokes some less common conditions, but they're there. And I think those connections are there. But I think it would be premature to start to speculate on those things without ruling out the practical of a DVT. But if we make progress on the marrow, I think you can start to draw connections with the skin. I would say the most morbid connections, in these patients are unfortunately devastating fungal infections like Aspergillus, mucor, and Fusarium. Those seem unlikely in a patient who's not progressing in that manner, but that would be the only thing I should mention out loud now, is if you're worried about the bone marrow and the patient has a febrile inflamed leg, don't just stop at bacterial cellulitis, think about the molds. But there are non-infectious conditions that do it too. But for the sake of time, I'll pass the mic to you, Mukund, to give us your final aliquot, and then we can go bananas nerding out about whatever's left.
Yeah, that sounds good. This is another case of me trying to think of how to present information to you in a way that was authentic to the way I received it. And the way I received the information initially was that it would have been so helpful to have this person's prior CVCs over the course of his many hospitalizations, but we didn't, and so we were unsure as to the chronicity of his pancytopenia, and so we ended up doing this workup. Eventually, we were able to get some more of that data, and we discovered that he did have chronic pancytopenia, and that his thrombocytopenia was worse on this admission than prior, but that the rest of his cell lines were kind of about where they had been for many years. So initially, we were all, I think, pretty gung-ho about considering MDS and transformation to leukemia and potentially getting a bone marrow biopsy from our perspective. But the case, decided for us and chose to evolve. So this is my final aliquot, but there's a lot here. Over the next few days, the leg continued to get worse. The patient had a hypotensive episode. He was brought into vancomycin and zosyn. And the leg itself began to change. A blister was seen, and it pretty rapidly progressed to a severe ulceration that required surgical debridement. A picture is worth 1,000 words. So if you're okay with it, Julia, I will take over the screen for just a second and share with you a picture of how this person's leg looked both before and after the debridement. Can you see that? So on the left is before the debridement, on the right is after. Leave this up for a few more seconds and then switch it back to Julia. Okay, go for it, Julia. So just to summarize, he's on vancomycin, his leg is getting worse, it needs surgery. They send intra-op cultures, which grow rare Bactrim-resistant MRSA. They also do an MRI of his right lower extremity, which shows non-specific tibial marrow edema without signs of osteomyelitis, diffuse soft tissue swelling of the right lower extremity without any focal fluid collections. Unfortunately, even on vancomycin and zosyn, the wound didn't improve. And so dermatology was consulted for repeat biopsy. The biopsy showed sparse inflammatory infiltrate with rare neutrophils and variable plasma cells. Stains for bacterial, mycobacterial, and fungal pathogens was negative. That's the end of my last aliquot.
Oof, wow, very, very intriguing. Now, Leah, what are you thinking?
So when you started to describe what happened and also the wound of the patient, first in my head I was considering mostly infectious etiologies and saying, okay, maybe this was some kind of a fungal infections, but something that is very aggressive, something like mucor that really is characteristic to like eat body parts quite aggressively like this. And then also seeing that he was only on antibacterial coverage, but not, did I see that correctly? Yes, but not fungal coverage. So that was one train of thought that I had. But then as we got more information, there was the workup is please correct me if I'm wrong, but as far as I heard it, the infectious workup, what did we have? We only had the MRSA that was positive, but then the staining and workup for other like fungal, mycobacterial, they were negative in this patient. And it's not, the treatment did not help anything. So in my head, I'm having like two thoughts. Is there still something infectious that's just went through our filters, or is this a non-infectious process? And for the non-infectious process, I was trying to find out with the derm biopsy if there's some kind of neutrophilic dermatitis sort of picture that we could link this to with the past medical history. But there's not really much that I hear because it's more, I think, rare neutrophils that I saw, and I'm not good at all at interpreting this, but there's no flavor in this direction that I get from just this biopsy with my limited knowledge. So now I'm wondering what could be aggressive like this, rapidly progressive, and non-infectious. And I think like this is where I'm going to need your help, because in my head I just have unspecific things like pyoderma gangrenosum or like aseptic abscess processes, but I'm not sure if they would present like this on the surface. Yeah, so I think that's where I'm at, and yeah, I would love to hear your thoughts about this.
Yeah, no, I think we first got a very humbling lesson about always knowing the time course of a condition to be able to solve it. And I appreciate Mukund helping us reinforce that lesson today. And so I think that the pancytopenia does fall to the background, but I think its relevance in terms of analyzing everything else can't be understated for the reasons I think you alluded to, Leah, which is that you have skin inflammation now proven by visual imaging, where you have soft tissue swelling, and so you know this is an itis. And what you're trying to figure out is it an infectious itis or is it something else? And I think that the sequence of events is so important. And the sequence of events here is this person develops a necrotic progressive ulcerative lesion in the context of a manipulation that previously wasn't there. So if you take a look at the presumed admission picture and the presumed current status picture, there's been a large ulcerative lesion that developed over that period of time. And I think the evolution of an ulcer this bad, this quickly, this severely is very evocative of a neutrophilic dermatosis. Because when cellulitis or other conditions worsen, they worsen not focally and burrow through the leg. They progress horizontally just as prominently. And so I think that the fact that this thing is choosing to progress in such a local manner is very evocative of that condition. And so are there exceptions to that? Of course. I'm sure Shema might remember the case of blastomycoses that we discussed together that can fool you. And so you always have to be humbled as to the possibility of being wrong. But this is where the idea that we should focus on infections and infections only is flawed. Neutrophilic dermatoses are some of the rare autoimmune diseases that can actually abruptly kill somebody. And not just kill them in the sense of causing local morbidity like it does to the leg, but as you're seeing in this case, there are systemic consequences to these conditions. And there's even a version of necrotizing neutrophilic dermatoses that can cause rapid septic shock and not septic shock, but distributive shock and subsequent death. So there are not many autoimmune conditions that you have to empirically treat before you know what's going on to save the patient's life. We empirically treat autoimmune conditions all the time to save kidney function, to save lung function, but for life-saving therapy, there's not that many. But neutrophilic dermatoses are one of them. And so here, I think the fundamental question is, because this patient has vexus and has a strong association with neutrophilic dermatosis, the pretest probability of neutrophilic dermatoses upon biopsy is moderate, I would say. And so the question is, well, what happens when you get a biopsy result that is not fully in keeping with a neutrophilic dermatosis. And this is what you said, Leah. You said, well, I would expect deep, dense neutrophilic infiltration. And the question is, how is that expectation tempered by the fact that the patient has a microscopically small amount of neutrophils owing to their VEXAS syndrome, and that he only has 1.6 neutrophils in his blood? How many should we expect in the skin biopsy? And I think nobody knows the answer to that. But it's the reason why neutrophilic dermatoses are broken down into typical and atypical, with typical cases of neutrophilic dermatoses being described in otherwise healthy hosts who are either pregnant or who have inflammatory bowel disease or who get it post-vaccination. Atypical neutrophilic dermatoses are ones that occur in patients with hematological fingerprints like leukemia or MDS, where the characteristic presentation and biopsy findings are now altered by the patient's underlying hematological process. So let me just articulate what I would do. I think that infection has not been ruled out, and the kind of infection that I worry about is one that is sneakily hiding in this patient's chest. So if I were the only person taking care of this patient, I would get a CT chest without contrast right now. And if that was clear, there was no evidence of blastose portal of entry, as we were humbled by earlier, or that more likely in this patient, that this patient does not have evidence of angioinvasive fungal infections on his CT chest, I would give him whopping doses of steroids, invoking the idea that the VEXAS syndrome can cause a severe neutrophilic dermatosis. Some people would not do the CT scan, would give steroids right away. Some people would not want to give steroids but give antifungal coverage. It's very, very tricky, but I think the range of possibilities are a fungal infection, mold, or endemic mycosis, but more and more likely, odds are this patient has a severe neutrophilic dermatosis, despite the biopsy results. And the explanation for that would be the cytopenia. So that's where I would probably go CT scan negative steroids. If the CT scan is not done, I think it would be a shame to not give this person steroids soon, either with or without concomitant antifungal therapy, because now clearly it's not just a fever and a rash, it's a systemic inflammatory response and a progressive ulcerative lesion. So the stakes are much, much higher. I'm curious, after all that rambling, if you have any thoughts or clarifying questions or any additional considerations that came to your mind, Leah, before we hear from Mukund.
I don't have anything to add. I made a note about atypical neutrophilic dermatoses because I would love to find out more, and I thank you for explaining that and breaking that down.
All right, Mukund, what you got?
Yeah, this was fun. We were in the same conundrum, Rabih, by the end, or rather dermatology and the primary team were, because at this point we had largely, as a hematology team, exited stage left, about whether this was an infectious process or an autoimmune process. And I think it was really hard to say one way or the other, because on one hand, you have multi-drug resistant MRSA growing from the wound, which is really hard to discount as a contaminant. And on the other hand, you have a biopsy, which is not clearly suggestive of a classic neutrophilic dermatosis, owing to the lack of significant neutrophilic infiltrate. But again, because this patient had so few neutrophils to begin with, it was hard to conclusively interpret that biopsy one way or the other. So the final diagnosis was taken to be VEXAS-associated neutrophilic dermatosis, and the patient improved on steroids. He was also discharged to a supportive nursing facility to finish off an extended course of IV vancomycin, just in case there was an infectious component to this picture. But he's doing well. I have a couple of teaching points to share from my own experience caring for this patient. I think this was a twisty case from start to finish. The differential was broad all the way until the end, and there were some really interesting diagnostic challenges. But a couple of things I learned that I was hoping to share with you all about VEXAS and about its manifestations. One, that chronic pancytopenia is very common in VEXAS. but so is transformation to myelodysplastic syndrome or leukemia, which is why we got involved, and which was the large amount of my personal involvement. Just a little point about the blood smear. The hypolobated neutrophils are also known as the pseudo-Pelger-Hewitt anomaly, with the pure form, the genetic form of this benign condition, Pelger-Hewitt anomaly, as opposed to the pseudo, being one in which almost every neutrophil is hypolobated or bilobated. It turns out there are some case series that identify pseudo-Pelger-Hewitt anomaly as a not uncommon finding as a benign manifestation of excess. And then just to highlight kind of the diagnostic complexity of this patient, both between hospitalizations across two systems that don't share data interfaces, with treatment as an infection, but worsening on treatment, and then with the challenges of diagnosing neutrophilic dermatosis in neutropenic patients. This was a really cool case to take care of, a really fun patient to get to know, and I'm happy to have shared it with you all.
I don't even know what to say, Mukund. I'll pass the mic to Leah to reflect on this case, but I think it is really incredibly cool that you brought this case to us, despite at the end having been a side player or an absent player in this case. But I think what you demonstrated so much is all the skill building that's required to present a case like this in a manner that really gets the most juice out of it. And I think the way that that is most apparent is by choosing to take us on the same pancytopenia journey that you did, and not giving us the advantage to really focus on the skin lesion, but the tension all the way. And it really allowed us to talk about a lot of bread and butter along the way. And ultimately, I'm glad that in a patient with VEXAS syndrome on VMR, their condition is still related to VEXAS syndrome and not true unrelated. But yeah, thank you so much. I know it takes a lot of work to figure out just how to present such complexity. And I encourage all of you to learn a lot from how Mukund did that. And if you're interested in learning more, the good news is we have a whole team to help you out, put your cases together. So thank you, Mukund. That was awesome. Now, Leah, what are your reflections on discussing in this case? And yeah.
I think I'm just amazed how rich this case is in terms of learning, and just I think we could have discussed this in 10 different ways and still spend 2 hours per discussion. And I loved how we had like rare diseases and got into depth for that, but then also had like, okay, how do we interpret a smear? What is, yeah, as you said, bread and butter interpretation. And I think that's, for me, always something I like to come back to when I'm overwhelmed with complexity of cases. What do I know? What can I hold on to? And then maybe start working from there. And then, because even the complex cases are made up of bread and butter components. So if you know the basics, then you can puzzle things together. So thank you, Mukund, for for taking the effort for making this such a rich learning experience, and Rabih for sharing this.
I don't know if I believe it's truly coincidental that Mukund did in fact give you the rheumatological gift of a very, very cool case in the room world. So thank you again, Mukund, and I'm glad that it was you two on the stage today. But it's now time to welcome Elena to take us through the teaching point.
Hi everyone. Hi everyone. Yeah, I'm gonna do the teaching points. And before, I want to say that Leah, I was really blown away by that discussion, and I think it goes to show you how much you put into this. And yeah, I learned so much. I will definitely watch this episode again. And I think I'm so happy that you got to discuss VEXAS, because I think it might be one of these conditions that let rheumatology move from classification criteria to actually diagnostic criteria. So that's really cool. And to quote Reza once again, were you entertained? And yes, Mukund, I was. So we started with unilateral leg pain, and we can split it into vascular causes, traumatic causes, skin and soft tissue causes, and neuropathy. I think the first thing when someone complains of leg pain is we're gonna look at it, right? And we want to see how deep the process might be, if the bone is involved, the muscle, or the fascia. Rabih reminded us that no misdiagnoses with leg pain are limb ischemia, and it's actually a diagnosis that is really hard to make, because even if pulses are present, or sensation or motor function, limb ischemia cannot be ruled out. And another no misdiagnosis are invasive fungal infections, and that is especially important in our patients due to the prolonged neutropenia. So at this point, we learned about the patient that they had a recent hospitalization because of diverticulitis, and we learned that they actually had systemic features of inflammation for a pretty long time. So at this point, we were asking ourselves, is the limb just finding a signature of a systemic disease, or is it something completely unrelated? And then we were nerding out a little bit about VEXA syndrome. That's actually a syndrome that is an acronym for multiple things that I don't have in mind right now, but you can definitely look up. And it has actually only entered the room heme world a few years ago, but actually has been reported in the literature for like a long time, but only the UBA mutation made it show up in the literature now. So it is an autoinflammatory disease of somatic origin that is X-linked due to a ubiquitination problem. Yeah, if you had that as a germline condition, then you would not be able to survive. So that's why we can find it. Because it is X-linked, males are more prone to getting this disease than women, but it has been recognized that women are also can also get this condition. So we have a heme part and we have a room part to this condition. And typical heme parts are that they have macrocytosis. They more frequently than the general population have MGUS slash paraproteinemia. Some have eosinophilia, while others have a myeloproliferative phenotype. And sometimes VEXA is only diagnosed after a diagnosis of MDS that, of course, can transform into acute leukemia. So from the room part, we have surface stuff and visceral stuff, and the surface conditions are centered around the face with, for example, oral ulcers that remind us of Behçet. We have ear, we have like polychondritis, we have eye involvement, we have urticaria, especially in the context of eosinophilia. And for the visceral part, we have usually a variable vessel vasculitis, we can have PNA. And the thing that is often very worrisome in these patients is that hypercoagulability state. And Shema said in the chat that as the patient is also on ruxolitinib, that even increases the risk of hypercoagulability. Another organ that likes to be involved is the lung in the form of ILD. And yeah, as mentioned before, the Behçet, the same concept can be applied to Behçet, another autoinflammatory condition. However, we usually don't see the neutrophilic dermatosis, but more likely like an acneiform rash or folliculitis. But it also has this problem of ultra hypercoagulability. All right. So another cool pearl that we learned is that when we are suspicious of limb ischemia and the condition is, however, restricted to the calf without foot involvement, it really decreases the likelihood of limb ischemia. So we should check that out. Leah then mentioned how we can approach pancytopenia in this patient, and often we think of a destruction problem or a production problem, but simply because all stem lines are involved, we think of a production problem most commonly. We can think of MADS, we can think of nutrition, infiltrative diseases, etc. And in the context of this pancytopenia with the condition of VEXAs, we were thinking, is what could there be like an antibiotic failure? So the body just cannot respond with an inflammatory answer. All right. And then in this context, Rabih mentioned that so we have 4 conditions where we really need to treat before we diagnose, and conditions where we need empiric antibiotic therapy is sepsis and decompensated cirrhosis, Rigoring, as it has a likelihood of like 40 to 70% of bacteremia, and febrile neutropenia, as we had in this patient. And we should especially watch out for angioinvasive fungal infections, thinking about the molds especially. So at the end, we were really left with a necrotic, progressive ulcerative lesion in the context of what we learned from Mukund, actually a chronic pancytopenia that was unresponsive to antibiotic treatment. And a really good clue is that it worsened with the manipulation, a phenomenon that we know as pathergy, and that really increased the likelihood of a neutrophilic dermatosis, especially in the context of vexus, which is a part of the disease. However, Rabih recommended that we should still watch out for the lungs before we give the steroids to exclude an angioinvasive fungal infection. Yeah, thank you so much.
Oh my gosh, that was unbelievable. Are you out of breath yet? That was just decoration and decoration of the core concepts with even more and more pearls. I love how you remember the number of patients who are bacteremic from Rigoring as an example of many of the times that you added even more knowledge to what we talked about. Thank you all. I hope you had a good time. Thank you, Mukund, for an amazing case, Julia for high quality scribing on such complexity, and Elena for the teaching points. And of course, what a gift to you, Leah, for getting to discuss a room case before you become an expert. So hopefully next time I will learn from you just as much as you learned from this whole conversation today. All right, guys. Bye.